Hello, everyone, and welcome back to another yet interesting topic from rheumatology, this time general medicine. And the topic we are going to deal is rheumatoid arthritis, which is a very important topic to be known. We'll quickly run through the overview. We'll be dealing today with the introduction, the pathophysiology, the clinical features, extraarticular manifestations, investigations. Under the investigation criteria for diagnosis is a very must known thing. Then we'll go through the management in normal cases and in pregnancy. So let's dive into the topic without any further ado. What is rheumatoid arthritis? It is a very common sort of inflammatory arthritis which is characterized because of its chronicity by clinical course of exacerbations, which means worsening of the symptoms gradually according to the time and further remissions. So the pathophysiology is very simple. It has both genetic and environmental components. In genetic, we have three main variants. That is, one is HLA DR beta 1, which has its molecules on 11, 71, and 74 positions. And then we have the single variants as HLA B1 at the position of 9 and HLA DP beta 1 at the position of 9 again. When we go to the environmental components, any stimuli can give rise to it or trigger this. For example, an infection. This causes the host proteins to enter the human body. And what happens is this host protein, they undergo some sort of changes, modification, and then they become immunogenic. Once they become immunogenic, they infiltrate to the synovium with macrophages, plasma cells, dendritic cells, and lymphocytes. And afterwards what happens is the once they infiltrate into the synovium, it forms lymphoid follicles in which both the T cells and the B cells interactions occur, and this causes an activation of the B cells which produce the cytokines and activations of the T cells which produce the cytokines and activations of the B cells which produce the autoantibodies, which includes the rheumatoid factor and ACPA, which means anti citrullinated peptide autobodies. And afterwards the tumor necrosis factor alpha is activates the synovial macrophages, and also the T cells, it produce the interferon gamma. And after which what happens is the macrophages, it produces several pro-inflammatory cytokines including tumor necrotic factor alpha, interleukin 1 and interleukin 6, which acts on the synovial fibroblast to produce further cytokines, and this causes a positive feedback loop to set in. So once this positive feedback loop set in, they cause proliferation of the synovial fibroblast, and this leads in turn to synovial hypertrophy. And they further produces matrix metalloproteinases and the proteinase, that is ADAMTS 5, which degrades the soft tissues and the cartilage. Now, there is not only this that causes it, we have prostaglandins and nitric oxide, which is further produced by the inflamed synovium, which causes vasodilation, and this causes swelling and pain. Then we learned that IL-6 is produced. So this IL-6 systemic release, it triggers and it produces acute protein phase that is discharged or released by the liver. And then this inflamed synovium is also known as pannus. At the joint margin, it directly invades the bone and the cartilage, and this causes joint erosions. Now, over this inflamed synovium, angiogenesis occurs. Angiogenesis means new blood vessel formation occurs, and this becomes very highly vascular. And then the pro-inflammatory cytokines, what it does, it goes and activates the endothelial cells. Now once this is activated, it goes and supports the recruitment of more leukocytes, which goes and perpetrate the inflammatory support. And after that what happens is this fibrous or bony ankylosis occurs, and muscles adjacent to the inflamed joints atrophy, and it might be infiltrated with lymphocytes, and this leads into a progressive biochemical joint dysfunction. And this further what happens is it amplifies the joint destruction. So let's dive into what is the clinical features we see. When we see the clinical features, we have typical presentation, acute onset, palindromic, and on examination what all we see. So in typical presentation we can see that there are there is pain, joint swelling, and stiffness in the joints, which affects basically the small joints of the hands, feet, and wrist in a symmetrical fashion. Then large joint involvement also takes place gradually. Then systemic symptoms develop, and extraarticular features are seen in the typical presentation. This acute onset, it majorly occurs during the old age, and how the patient presents themselves is they'll be having severe early morning stiffness along with polyarthritis, and pitting edema also would be seen. In palindromic cases, what happens is there would be proximal muscle stiffness, which mimics polymyalgia rheumatica, and then they would be showing relapsing and remitting episodes of pain, stiffness, and swelling that would last only for a few hours or days. Now, when we go for examination, on examination, we'll be seeing that there would be certain swelling and tenderness on the affected joints, and characteristic deformities would be seen on long-standing uncontrolled diseases, uh, like subluxation of the MTP joints, the feet, etc. I'll be showing that in the further video. So this is one of these are few clinical features, that is the deformities that we would be seeing on examination. This is known as a swam deformity. If you see in the swam deformity, you would be seeing that the proximal interphalangeal pharyngeal is in hyperextension, and you would be seeing that the distal interpharyngeal is in flexion. Then when we go to the Bondinier deformity, you will be seeing that the proximal interpharyngeal is in flexion, while the distal interpharyngeal is in hyperextension. Next, we'll be going for the Z deformity of the thumb. In this, you would be seeing that the interpharyngeal would be in the flexion, while the metapharyngeal would be having hyperextension, and the CMC would be having another flexion over there. This is a X-ray depicting this dorsal subluxation of the ulna. If you see over here, you can see it very clearly. Then we'll be seeing about the subluxation of the MTP joints, are the metatarsophalangeal joints of the feet. If you see over here, you can see that there is an overlapping of it. This is known as the subluxation of the MTP joints. Then we'll see the valgus deformity. You can see over here a bulging out of the bone. This is known as the valgus deformity. Next, we'll be seeing the flat foot. So this is a depiction of a healthy foot, and this is a flat foot. We have the Baker cyst. If you see over here, there you would be seeing a cyst formation. Then we would be going into the extra-articular manifestations. So in systemic, we would see that the patient develops fever, fatigue, weight loss, and they have more higher susceptibility to the infection. When we go to the musculoskeletal, we see muscle wasting, bursitis. This is an example of bursitis. You can see in the mirror, image clearly. Tenosynovitis, that is over here. And then osteoporosis and tenosynovitis and all. You can also see that this patients and all complains with carpal tunnel syndrome too sometimes. And then we'll go into the hematological way. In hematological manifestation, you'll be seeing anemia, eosinophilia, and thrombocytosis. And in nodules, you will be seeing sinuses and fistulae. When you go for lymphatic area, you will be seeing Fetty syndrome and splenomegaly. If you see over here, you can see an MRI depiction of the splenomegaly over here, and then you can see the gross findings, and this is an example of Fetty syndrome. Next, we'll go for the neurological way. Here, if you see this MRI, you can see that there is a cervical cord compression over here. So this is one of the manifestations seen. This is the cervical cord compression, and there will be peripheral neuropathy, compression neuropathies. Compression neuropathies is the one that I said might cause carpal tunnel syndrome. Then we have mononeuritis multiplex. When we go to the ocular way, if you see over here, this is an image that depicts episcleritis. This image depicts scleromalacia. If you see over here, you can understand a scleromalacia. This is an example of scleritis, you can see over here. And this is an example of keratoconjunctivitis sicca, that is reddening of the eyes occurs over here. When you go to the vasculitis, you see digital arthritis. Then you see mononeuritis. This is digital arthritis, if you can see. and you go to the mononeuritis, then you have multiplex ulcers. Hmm? And then this is mononeuritis, you get multiplex ulcers. Then you have, this is the visceral arthritis, and this is an example of pyoderma gangrenosum. Then you go for the cardiac manifestations. In cardiac manifestation, if you see, this is an image of a normal heart, and this is an image of how a pericarditis would show. And then they get conduction defects, they also undergo myocarditis, which is the inflammation of the heart muscles. If you see over here in a diagrammatic presentation, it has shown that there is an inflammation of the heart cells. Then if you go, you can see further a coronary vasculitis. You can see over here a vasculitis formation. Then endocarditis over here, and this is granulomatous aortic. It often presents itself like MI, but actually it isn't. So now we'll be learning about the pulmonary extra articular manifestations. So if you see over here, you can see the Kaplan syndrome. So there, it occurs basically when a patient in occupational hazards, when a patient inhales a lot of silica dust. Firstly, it forms a pulmonary nodule. It can also lead to pneumoconiosis, and it also manifests itself as rheumatoid arthritis. You can see over here the variations in the color or the quality of a healthy lung and the infected lung. And you see over here pleural effusions over in this x-ray. This is an example of pneumothorax. You can see over here pneumothorax presentation. This is bronchostasis. You can see over here a honeycomb appearance in the lungs. This is bronchiectasis. You can see over here pulmonary fibrosis. If you see, you can see tiny fibrosis over here. And this is this obliterative bronchiolitis that can be seen in the MRI. You can see over here delayed airways, and then there is this tree in bud appearance over here, which is a classic signal of obliterative bronchiolitis. Then you can see over here a normal lung and the air trapping in growth of the blood vessels in this MRI. Now we go to other extraarticular manifestations. You can see amyloidosis. This is a form of amyloidosis doses, and then you can see generalized or localized lymphadenopathy, like in this picture. Next we'll be dealing with the investigation. So we basically do investigations for different ways. One is to establish the diagnosis. So the first one is to establish the diagnosis. In that, firstly we need to know about the clinical criteria. So the clinical criteria over here is based on scoring. Okay, now based on the scoring, what happens is, here you can see in the screen joint involvement has a point of 0 to 5. If one medial or large joint is involved, then a 0 point would be given. 2 to 10, then 1. 1 to 3 small joints, then 2. 4 to 10 small joints, 3, and vice versa, and so on. Then in serology also, if neither the rheumatoid factor nor ACPA is positive, then 0. If at least one test show a low positive, then it would be 2. If at least one test show high positive, it would be a 3. Same goes with the duration of synovitis. If it is less than 6 weeks, we'll go for 0 points. If it is greater than 6 weeks, according to the history of presentation, it is 1. When you go for the acute phase reactance, 0 to 1 point would be given. If neither of CRP nor ESR is abnormal, we'll be giving a 0 point. If both of them shows abnormal values, then we'll go for 1. So at last what happens is, if a patient has a score of greater than 6, then they are considered to have rheumatoid arthritis. Now further we'll be seeing that the rheumatoid factor and the ACPA, that is the anti-citrulline peptide antibodies, would be positive in 70% of the cases. There would be an elevation of the ESR and the CRP, and then we can also go for USG and MRI. Only MRI is done only if we are uncertain if there is a presence of synovitis or no. The next one is we do to monitor the disease activity and the drug efficacy. So we will be dealing with the pain. We will do visual analog scale. Then we'll go for the joint swelling, joint tenderness. Then we will ask the patient if they have a history of early morning stiffness. Then we will check for the values of ESR and CRP. And then if you see over here, you see DAS 28. So DAS 28 is actually a calculation which involves the count of swollen joints. That is, if you count over here, these are the swollen joints if you see. So how many swollen joints are there, and count the tender joints, which all positions in these joints do the patient have tenderness. And then we have to measure the ESR, and then we have to measure or note down the patient's global health assessment from the point of 1 to 100. And then we need to enter the data into the calculator in a website known as www.4s-dawn.com/das28. And the interpretations would be somewhat like this: if it is greater than 5.1, it is of high activity. If it is greater than 3.2 to 5.1, it is of moderate activity. If the value is 2.6 to 3.2, it has low disease activity. And if it is less than 2.6, it is a remission. Next is to monitor disease damage. So we would go for an X-ray. It can be lateral view. It can go for cervical spine flexion and extension, and anterior posterior view also. Then we'll go for the functional assessment. Next, we'll go for the investigations. Now we do for monitoring the drug safety. We can go for urine analysis, urea and creatinine, full body count, and liver functions test along with the chest X-ray. For management, we focus mainly on the control of symptoms, the control of inflammation, and then prevention of the joint damage. So we have pharmacological treatment over here, non-pharmacological treatment over here, as well as surgery. When you go for the pharmacological treatment, if you see over here, what happens first is, when a new diagnosis of rheumatoid arthritis come, okay, we give them a drug treatment. That is, we give them a drug treatment of adjuvant drugs. Mostly we give methotrexate, that is 15 milligram weekly. If it if it is required, we'll escalate the dose to 25 mg, and along with the corticosteroids. Corticosteroids means we'll be giving them prednisolone for 30 mg daily, and then we'll decrease the dose by 5 mg per 2 weeks, and then gradually stop it. We can't stop it at one stretch. Then we will be also giving along with that, if we will be checking the DAS 28. Okay, so once we check the DAS 28, if the value is less than 3.2, we will continue with methotrexate itself. But if the DAS value is more than 3.2, we will add sulfasaline and hydrochloroquine. And the value that would be given is around 200 to 400 mg for hydrochloroquine. Um, it can be once in a day or twice in a day. And it would be given in this form, that it should be uh, less than 5 mg per kg. And then for sulfasalazine, we'd be giving 500 mg initially, either one time a day or twice in a day. And then we'll maintain the dose to 10,000 to 1500 mg twice in a day. Okay, then we will be seeing, if again we will check with the values of DAS 28. If it is then less than 3.2, we will continue with methotrexate, sulfasalazine and hydrochloroquine. And after that, if the value is between 3.2 to 5.5, we will consider the subcutaneous methotrexate and different CDMARDs. Okay, that is disease modifying antirheumatic drugs. And then if you see DAS 28 is greater than 5.1, we would be also adding with them biological TS, targeted sympathetic DMARD. And if the DAS after addition of this biological DMARD, that would be TNF alpha inhibitors, interleukin 1 inhibitors, interleukin 6 and interleukin 6 receptor inhibitors, anti CD20 antibodies, CD80 bar 86 CD28 inhibitors, JAK inhibitors, if these are the ones, if this causes the decrease to 3.2, we would continue the therapy. In case now it is more than 3.2, we would consider a change to different biological or targeted sympathetic DMARD. Now, when we consider the subcutaneous methotrexate along with different different C DMARD, we have to check again the DAS value. Now if the DAS value is less than 3.2, we would continue the therapy, but if it is more than 3.2, then we would go to the biological TS mark. Now for the non-drug treatment, we have physiotherapy and surgery. Hmm? In physiotherapy, we can take occupational therapy as well as psychologist support. In surgery, we have synovectomy that helps in the joints that have failed to respond adequately to any sort of systemic therapy and any sort of intra-articular injections. Then we have arthrodesis, we have joint arthroplasty where secondary osteoarthritis evolves. Then we have metatarsals osteotomas. Allah had excision with wrist synovectomy to prevent overlying extensor tendon rupture. Then we have the upper cervical spine fixation where there is progressive atlantoaxial subluxation. And then we have joint replacement, we have joint fusion that is on the wrist or triple hand foot. This decreases the pain where joint changes are severe and advanced. And then we can also go for the natural treatment over here. Now, when we go to the management in pregnancy, what happens is first and the foremost thing is if a couple or if a parent is planning for conception. So, before 3 months of the conception, you need to discontinue the usage of methotrexate. And for leflunomide, you have to stop it 2 years prior to the conception of family planning. Now, if you're for control of the pain, we give them oral analgesic, that is paracetamol or acetaminophen, that we can give 1 to 4 grams per day throughout the pregnancy. And we can give them oral NSAIDs and selective cyclooxygenase 2, that is COX2 inhibitors, that is after the implantation, that is 20 weeks of gestation later only we can give this. And then we can give them glucocorticoids, that is to control the disease flares. However, there is high maternal risk of hypertension, glucose intolerance and infection. So though it is risky, we can give, but it should be controlled or discontinued at week 32 of gestation to avoid this preeclampsia and further complications in delivery. Then the only DMARDs that can be used over here is sulfasaline, salicine, azithromycin, and hydroxychloroquine because it controls the inflammation. However, we should avoid the drugs like methotrexate, gold, cyclophosphamide because they can be tetragenic for the baby. And then we can also give them anti-tumor necrosis factor gamma treatment. It's mostly suggested that we give certolizumab because it does not cross the placenta in appreciable amount, and immunosuppression in the neonate is the only side effect that is seen in it. The contraindication in breastfeeding are the drugs like methotrexate, leflunomide, cyclophosphamide. So that was the video for today. I hope you like this video. If you like this video, don't forget to like, share and subscribe to our channel. We'll be coming with further more videos. Till then, stay tuned and happy learning. This is Ashna Viraj signing off for today. Bye.